Good evening to all my colleagues, and I am really grateful to MSN Lab who has done such an academic endeavor so that this reaches to the general doctors and physicians and gastroenterologists. This molecule, these are small molecule, what we call the small molecule, because this is the only orally active molecule which is not like vedolizumab or others which are injectable forms. But this is really good because it's absolutely less side effect. So Dr. Viker, I will be discussing about this, but I will just discuss about briefly about what are the ulcerative colitis drugs which are used. Just briefly, I will mention that. Before that, I'll start sharing my slides so that it will be easier for me. Are my slides visible?
Yeah, absolutely.
Okay. Yes, so this is basically the how this tofacitinib works, that JAK-STAT signaling pathway and pathogenesis. I'll just briefly touch upon those pathophysiology. And this will incorporate evidence. There are so many trials for JAK-STAT inhibitors used, like Octave 1, 2, Octave 10. These are the trials. I will be discussing that, or if there is no problem, we can talk about that at the discussion point. So this is the diagram which I will be showing you at the end, because just to see to the left of this, you can see this to the left is that how this innate immunity comes. If there is a mucosal membrane is intact, in healthy state, how the AGA dimer, this mucosal epithelium and the mucin layer, how this is protected. Once in disease, that this tight junction is disrupted, how this inflammatory cells they work, I'll tell in the subsequent slide. This is the normal end or healthy state, this is the disease state. And this is where this inflammatory mass, where this innate lymphoid cell, where the JAK-STAT inhibitors work. This is interleukin 13 mediated, Th1 and inflammatory macrophages. This is how this JAK-STAT inhibitors work. I'll discuss subsequently when I'll talk one by one. So this is a small model of IBD. If you understand this diagram per se, then you have understood how all the molecules, the newer molecules work in IBD. So basically, as you know, briefly touch on what is ulcerative colitis. It is an autoimmune relapse-remitting chronic disease of large intestine in which lining of the colon becomes inflamed and develops into tiny ulcers or sores. It has a chronic inflammation of the large intestine, further triggers the symptom of ulcerative colitis like recurrent diarrhea, abdominal pain, cramping, fatigue, weight loss, blood in stool, and intestinal blockage, sometimes sores or ulcer. As I already mentioned, prevalence rate of UC is 44 per 1 lakh population. Look at this, how this pictorial representation, this is for the general, this is how the normal colon looks when there is ulceration, loss of vascularity, edema, erythema, ulceration, how this in ulcerative colitis, it looks on a colonoscopic view. So what are the factors which causes it? You must know that there is some genetic susceptibility, and specifically it is very relevant with Crohn's disease. Environmental factor, again, Crohn's disease has got very relevance as compared to ulcerative colitis. And immunological factor, how the immunology works and how the drug metabolism has a relation to the immunology. This can be a topic for discussion. It will take 1 hour. What are the immunological factors? The environment factor like bad eating habit, like junk food, spicy, or lack of fiber in the food, poor lifestyle. Genetic factor like gene mutation or chromosomal damage changes in some drug metabolism. Immunological factors such as autoimmune disease, which because maybe reduced gut flora. The flora acts as a symbiosis. If there is a problem with the gut flora, it's called dysbiotic change. It could be mild, moderate, severe. Rectal bleeding with less than 4 bowel is mild. Rectal bleeding with more than 4 to 6 bowel motion is moderate. Rectal bleeding is more than 6 bowel motions with a systemic illness, or if hypoalbuminemia is there, less than 30 gram per liter, it's called severe. So in mild initial damage of the mucosal layer of the large intestine, in moderate to severe, there is increased cytokine levels due to tissue damage and recruitment of immune cells, which result in inflammation and further tissue damage. This is important. Increased cytokine level due to tissue damage. Exaggerated cytokines which trigger further overstimulation. Cytokines will again stimulate the immune cells, leading to chronic inflammation with ulceration across the linings. So complication could be acute like toxic megacolon. These are the indication for surgery. Toxic megacolon perforation and hemorrhage. Here we don't some form of hemorrhage, mild form of hemorrhage, you can start with intravenous treatment, but in severe hemorrhage, there can be consideration for surgery. What are the chronic complications? Long-time ulcerative colitis can lead to cancer. Usually, these are the multicentric because of the dysplasia sequence, extra elementary manifestation like skin, erythema multiforme, and pyoderma gangrenation, eye problems, and liver diseases could be there. So coming to the pathogenesis, on the physiological condition, homeostasis normally exists between the commensal gut flora, epithelial cells that line the interior of the intestine, and the immune cells within the tissue. There I had a gross picture, but individually I am separating out now. This is the normal microbiota. This is the commensal microbiota. This is the anti-inflammatory bacteria, and these are the red ones are the pathogens. How the pathogens trigger this damage? Because there is an unstirred and this is the lumen, and this bacteria pathogen has to access this. Unless there is a damage to the epithelium or a damage to the tight junction, they cannot access to this. So if there is a epithelial barrier is disrupted, normally there is a IgA and mucous membrane protective tissue is there, and in the lamina propria there is like T helper cells, barrier function regulatory 3 gamma, interleukin 10 regulatory lymphocytes, and they help in physiology of inflammation or pathological inflammation. If there is physiological, it's called homeostasis. If there is pathological, it's called a disease state. So it can start from the intestinal lumen to mucous layer, epithelial barrier problem, or lamina propria problem. All these mechanisms, this lamina propria is the site where all these newer molecules work, anti-integrins and JAK inhibitors work. So this homeostasis is disrupted in susceptible first by specific environment like diet, antibiotics, stress, genetic factor, resulting in hyperactivation of the T helper and T helper 17 type of cells, increase in tight junction permeability. This you can see the tight junction. And if there is increased permeability, because this is the tight junction which is tight, but this is the increased permeability there where the microbiome has already gone inside this lamina propria. So once that is in the lamina propria, that causes chronic inflammation and ulcerative colitis. You can see host genetic factor already I've mentioned that host genetic influence like NOD2, ATG, IL-23R, CARD9, and environmental factor like diet, antibiotic, and stress. So already 3 things are operating: autoimmune, host genetic factor, and environmental factor. So involvement of dysfunctional response from the innate to adaptive immune system, multiple inflammatory cytokines are overexpressed, amplification of immune response lead to phenotypic expression of the disease, mediated dysfunctional cell-cell interaction in innate adaptive immune response pathway. Look at this. This is the epithelial barrier. This is the microbiota that has come into that the tight function is disrupted. And this is a dendritic cell with pseudopods, and mucosal immune system is activated, and the recirculation of the inflammatory like pro-inflammatory cytokines are there. So this how it works from the endothelium. What is that adhesin, anti-integrins and things? This will be talked about when I will be talking about this slide proper. So look at this. This is the activated dendrite cell, and macrophages and activated dendrite cell. Once they are activated, that the T helper cell, and this is the nerve T cells which are activated by activated dendritic cells, and they in turn give it up to interleukin 4 natural killer cell, and T regulatory cells are good cells. They try to help. They try to suppress the inflammation. Most important is look at this colonic lumen. This is the mucous layer, and this is the mucin. If it is depleted, if the mucin is depleted from here, look at this, how these junctions and mucus is covering with epithelial layer causes increased permeability of the intestinal epithelium, resulting in increased uptake of luminal antigens. So if the mucin layer is also a problem, this is a commensal microbiota change to pathogenic microbiota, and the tight junction is a problem. All these cause to activation of the dendritic cells, and the activation of the macrophages causes processing of microbial like TNF alpha. So all the molecules, anti-TNF agents, anti-interleukin molecules, anti-leukin agents are acting here. And similarly, we have cells, how this is there. One thing one should, what is the MADCAM? This is from the specific intestinal endothelium, and ICAM1 is in endothelium of everywhere in the inflammatory area. But if you look at the MADCAM, this is very specific to the endothelium of the intestine. So from the system circular, they help in prevention of lymphocyte trafficking. So if there is a lymphocytic trafficking, then this lymphocyte will not further aggravate. And if there is a problem with apoptosis causes programmed cell death. If someone is preventing this apoptosis, like upregulation of inflammatory thermokines leading to recruitment of circulating leukocytes, which perpetuates the cycle of inflammation. This is important. Upregulation of inflammatory cytokines. This circulating T cells bearing integrin alpha 4 beta 7 bind to colonic endothelial cells of the microvasculature. Addressing cells, adhesion molecule 1, whose expression is enhanced in the inflamed intestine, leading to increased entity of gut-specific T cells into the lamina propria. So from the endothelium, these lymphocytes go into lamina propria, causing further inflammation. So if someone can prevent this trafficking of the lymphocytes, then that will be useful in patients with ulcerative colitis. So again, this is the photograph which I had shown there. Look at this. This is the IgA dimer, immunoglobulin A dimer, which is acting in the epithelium. This is lying in the mucin layer, below the mucin layer. This is the IgA dimer. This prevents the microbiomes to here. And here is the Paneth cell. Paneth cell, this is the mature dendritic cell. This is the gut homing T cells. And look at this. Once there is inflammation, interleukin 23, interleukin 12, all these are inflammatory cells. And the T helper cell, T regulator cells are benign cells. They try to control the inflammation. And autophagogens, they control by ingesting bacteria. And this, look at this innate lymphoid. These blue ones, these are the innate lymphoid. This is important. Why innate lymphoid important? Innate lymphoid cells contain the JAK-STAT pathway. And interleukin 3, they are mediated through interleukin 13 and TNF alpha. T helper cell and inflammatory macrophages can cause TNF alpha, and TNF alpha can aggravate or stimulate these innate lymphoid cells. Once innate lymphoid cells from the lymphatics migrate from there, that can cause further inflammation. So treatment goals is basically induction of remission, maintenance of remission, prevention of complication. So therapy-related allergy, intolerance, infection, lymphoma, one should know what causes lymphoma, and steroid side effect. Just briefly, I'll touch one by one. This is the classification of ulcerative colitis drug. I just mentioned the name because time is very short. Aminosalicylates is the common A, which is from Azad Khan. It started aminosalicylate. When it was associated with the sulfasalazine was the molecule, azo-reductase of the colon breaks down to sulfa and 5-aminosalicylate. 5-aminosalicylate is the active moiety. And corticosteroids subsequent, then immunosuppression like azathioprine, methotrexate, antimicrobial like metronidazole and ciprofloxacillin, TNF alpha inhibitor, which is commonly used are infliximab or adalimumab. There are so many trials like ACT1, ACT2 trial, adalimumab Ultra 1 and Ultra 2 trial. JAK inhibitors like uracilumab, baricitinib and tofacitinib. What we will be discussing today about tofacitinib, the octave 1, octave 2 and octave sustain trial. And finally, if they don't respond, you can go for surgery. So this is a medical treatment. This is a 5-ASA. There are two approaches, step up and top down approach. So 5-ASA, corticosteroid, thiopurine, cyclosporine, biologicals. So this is how it's sulfasalazine work. I have already bacterial reductase breaks it to sulfapyridine and 5-aminosalicylate. There is no therapeutic action of sulfapyridine, but action is 5-aminosalicylate. All the side effects are because of the sulfapyridine. Corticosteroids used in acute treatment, they are longer acting like budesonide 9 mg, MMX technology. It acts, it disperses in colon, it can be used. And rectal administered for the topical use can be used. Thiopurine is effective for maintenance of remission. And dose already mentioned 2 to 2.5 here, 6 mercapto is 1 to 1. Azathioprine is converted to 6 mercaptopurine in the body, so to be active in the healthy state. So cyclosporine used to treat hospitalized patients because it's intravenous preparation 2 to 4 milligram per kg. Side effects are nephrotoxicity, opportunistic infection and seizures. Biologic like anti-TNF and IgG monoclonal antibody directed against TNF. It is the next toxic alternative to cyclosporine for patients with severe steroid refractory disease. Effective for both induction and maintenance of remission. Preparation usually we use infliximab, induction of remission by 5 mg per kg IV at week 0 to 6, and maintenance is 5 mg per kg every 8 weeks. Every 2 months we give them. We start with induction with very quick every 2 weeks, then 6 weeks, and every 8 weeks you are giving this. So this is end of my slide. I intentionally didn't touch upon the newer molecules and tofacitinib in this because Dr. Rai will be talking about that. So with this, I must thank you. There are so many trials I didn't discuss today. I'll thank you for your patient hearing. If there are any questions, I will take at the end when we'll discuss.